Hi everyone. I am going to talk to you guys about um, we are going to talk about chapter 7, evidence-based practice, and I'm actually posting this lecture during week 2 as well, just if you guys want to look at it for your poster board presentation. So, okay, evidence-based practice and quality improvement. So, evidence-based practice is the best approach for managing issues based on evidence, right? We do this all the time, especially now, all healthcare. The main thing is evidence-based practice. And I remember when I first started, and it wasn't that long ago, I'm not very old, um, where evidence-based practice was a new thing. And some of the older clinicians, whether they be nurses or doctors or whatever, were kind of like, oh, we've always practiced evidence-based practice. That's just a buzzword. But really, it's really come into its own, and it's really cool about using the best practice, the best evidence to do everything you do, and questioning, is this the best practice that we could be doing it? Or are we still doing it because it's something we've always done? And I know that sounds weird and I'm kind of repeating myself, but I can't help myself. Evidence-based practice gets me excited. So what research has been done that can provide clinical practice guidelines? So a question would be, what's the best approach for managing neuropathic pain in the terminally ill patient, right? So there's two things we do. There's quality improvement and there's research, okay? When you're looking at quality improvement, you're thinking, how do we know? How are we measuring patient outcomes? How do we know what we're doing is best practice? And if we want to implement other practices for best practice, how do we know what we're doing is right? So how do we measure outcomes in neuropathic pain? Are we using surveys? Are we doing qualitative type measurements? And then research. So what's been studied and where are there gaps? Where has there been long-term research that has been multi-centered, hopefully, controlled and double-blinded, and if not, long-term qualitative study. So what works better than A and B? What is it like to live with neuropathic pain? All right, so commonalities that provide structure. So evidence-based practice, it utilizes the best clinical evidence in making patient care decisions, and it's typically from the research. So evidence-based translates knowledge into practice. We are using knowledge, evidence into our everyday practice. And quality improvement is a system to monitor and evaluate the quality and appropriateness of care based on the evidence and research. Okay, so we're looking at outcomes and processes. Research applies actual methodology, whether it's quantitative or qualitative, to develop, uncover, create, find, and add new nursing knowledge. Okay, commonalities improve care and delivery. Whether you're doing research, quality improvement, evidence-based practice, the overall is to gain new knowledge and to improve the standard of care. It involves teamwork. So here's the deal. In all those three areas, you're not going to do it alone. You need some critical thinking and creativity and a commitment. You're not going to stick with these things if you're not committed to improve care. And one informs the other. Quality improvement can inform you as to new research that's needed. Research can inform you as to quality improvement that's needed, and the same with evidence-based practice, okay? Research starts in practice, ends in practice. Quality improvement evaluates and monitors care and identifies opportunity to improve care as processes and outcomes are measured, all right? Nursing base their practice on emerging evidence from research. So I can tell you that even some stuff that was emerging as the evidence-based practice, can be disproven, and then you're looking for new stuff. So even now with pain management, since we're on that line, it's fluctuating again, and that's why we're kind of in the trouble that we are. For those substance abuse people, I know that we have some nurses that focus on that here. You can certainly attest to how the focus has changed several times in the last, 15 years ago, 10 years ago, 5 years ago, and now. All right. So evidence-based practice, conscientious use of current best evidence to make decisions about patient care. It's problem-solving approach to clinical practice based on systematic search for appraisal of most relevant evidence to answer questions, one's clinical experience and expertise and patient preference, and constantly improving and learning on what you do. Because you are conscientiously knowing, entering into an agreement with yourself and with your employees and with the patients that you take care of, that you are going to strive and know that you're going to have to make changes all the time in what you do so that you can give the best patient care. So it's a problem-solving approach to clinical practice. So there's systematic search for and appraisal of most relevant evidence, one's clinical experience and expertise, and patient preference and values. So a few things to get in with that. If you're constantly reading stuff or going to competencies, which we all have to keep up our license, this stuff will naturally come up. We're comparing our outcomes to benchmarks that other people make, and that's going to come up as well. You know, if you work in primary care and you have to look up your child, make sure your childhood immunization rates are up there and you're not doing it, looking at, you know, research in order to figure out what the best practice is to get that. If you're in wound care, making sure you're keeping up with best practices to improve your wound healing rates. So, and then one's clinical experience and expertise. So why do we change things? Maybe you're finding that this doesn't make any sense. I've been doing this for 20 years and it never makes sense, or it made sense at one point when we didn't have computerized systems, but now that we do and we get more answers, why are we still practicing these things? And in healthcare, we have this idea called sacred cows, where we protect old practices because we've always done them. And then patient preference and values. All of our patients are different and our world is getting smaller and we're introduced to so many different types of preferences and values, and you're going to have to find ways to support that. So think about someone who's Jehovah's Witness and they really don't want a blood transfusion, but they need a life-saving surgery. What are some things that you could do? There's a lot of evidence out there for blood-sparing procedures, non-blood product volume things out there that they use based on the fact that you had someone who said, I cannot, my religion prevents me. The core of my body, of my soul and being says, I cannot get this blood transfusion. What are you going to do to take care of me? And, you know, that's where some of this stuff came up.